Sure, yeah. So just to remind everybody, Keynote A18 was an international randomized double-blind clinical trial in patients with high-risk locally advanced cervical cancer. And for the purposes of A18, this was defined as patients with stage 1B2 to 2B cervical cancer that was node positive, or patients with stage 3 to 4A cervical cancer, regardless of lymph node status. And this was FIGO 2014 staging, not the current FIGO 2018 staging. And patients were randomized to receive chemoradiation plus pembrolizumab, followed by pembrolizumab maintenance, or just standard of care without pembrolizumab. So we previously reported the first and the second interim analysis, which showed overall statistically significant advantage for PFS and OS. And the final analysis confirms those findings, and also no new safety signals were identified. So this is really encouraging results. So let me answer your second question first. So with respect to biomarkers, we did look at PD-L1 as a biomarker, because this was a biomarker naive trial. But 95% of the patients on the study had PD-L1 positive tumor. So it's really hard to make any conclusions about the value of PD-L1 in this setting as a biomarker. I think that we believe that adding immunotherapy to chemoradiation potentiates the mechanism of the immunotherapy by using the radiation to increase the immune response in the tumor, thereby making the immune therapy work better. I don't think we know the answer definitively to whether using IO first or using IO after or using IO during chemoradiation is going to be the most effective. But what we do know from this study is that adding it to chemoradiation and then using it as maintenance is a successful strategy. So I can't exactly answer your question based on this trial, but we do know that this way of giving it seems to be effective. So based on biomarker, no, I don't think so. Well, at least not on PD-L1 expression, because that doesn't seem to be a good differentiator. The majority of tumors, as we said, are going to express PD-L1. I think applying this treatment strategy to the patient population that was tested on the study is very reasonable. And in practice, in the United States, we're doing that now for this high-risk, locally advanced group of patients.